Today our topic for discussion is external cephalic version and reducing the incidence of term breech presentation. Reference is Green Top Guidelines number 20A, published in March 2017. So now we will start with the introduction. Introduction and background epidemiology. Breech presentation complicates 3 to 4% pregnancy of the term deliveries and is most common in nulliparous women and in the preterm delivery. This is one of your SPA. That how much it complicates, that is 3 to 4%. How effective is ECV in non-cephalic birth? Women should be informed that success rate of ECV is approximately 50%. This is one of your SPA. Women should be informed that after unsuccessful ECV attempt at 36 weeks of gestation or later, only few babies presenting by breech will spontaneously turn to cephalic presentation. Women should be informed that few babies revert to breech after successful ECV. Women should be informed that a successful ECV reduces the chance of cesarean section. So you have to tell the patient about all these things that after unsuccessful ECV, few babies will presenting by the breech and some will spontaneously return to cephalic. What is the success rate of specifically? Overall success rate is 50%, but in those with the having multiparous women, success rate is 60% and nulliparous women is 40%. So this is one of your SPA, that overall success is 50%, but specifically for multi 60% and for nulliparous 40%. This paragraph is also important in percentage point of view. Spontaneous version from breech to cephalic is usually at term occur only 8% of the primary gravida after 37 weeks of gestation. So when you will not do ECV, the spontaneously the breech will return to cephalic, that is 8% chance. And when ECV at term has been unsuccessful, that only 3 to 7% of the baby will spontaneously return to cephalic presentation. So without ECV, change to cephalic is 8%, and after ECV, if it is unsuccessful, then there is 3 to 7% chance that it will spontaneously return to cephalic. Spontaneous reversion to breech after successful ECV is rare, occur only in 3% in the largest series. So you have to memorize this, that breech to cephalic without ECV 8%. Breech to cephalic unsuccessful ECV, that is 3 to 7%. And spontaneous and breech to cephalic successful. Then after that, when it is the third thing is that when the ECV the baby got cephalic, but after successful ECV, it will return from cephalic to breech after ECV, that is 3%. So these 3 percentages are important. Does ECV affect the outcome of labor? Women should be informed that labor after ECV is associated with slight increased rate of cesarean section and instrumental delivery when compared with spontaneous cephalic, because obviously there is chance of risk of abnormal fetal heart rate, and that patient may need later on need of cesarean section, because one of the complication of ECV is a fetal bradycardia. Can the success of ECV can success of an ECV attempt be predicted? ECV success can be predicted to some extent, but use of model to predict success should be not routinely used to determine whether the ECV can be attempted or not. So the success rate depend upon the multiple variables. It shows that multiparity, non-engagement of breech, use of tocolytics, a palpable head, and a maternal weight of less than 65 kg were predictor for successful ECV. Other factors such as posterior placental location, complete breech position, and an AFI greater than 10 centimeter also predictor for successful ECV. So these are the predictors that you can predict that maybe the ECV could be successful in these specific patient. When you will if the patient is multiparata, you will use tocolytics and the palpable fetal there will be complete breech and posterior placental location and AFI of greater than 30 centimeter. So model have been developed to predict ECV success. Different strategies are summarized. These model of insufficient predictive value. So they have a low predictive value of these, but we can just assess the patient like this. What method to be used to improve the success rate of ECV? Use of tocolytics and beta mimetics improve the success rate. When you are planning for ECV, the prerequisites for ECV is that you will give tocolytics to relax the abdomen, and with beta mimetics. Routine use of renal analgesia or neuroaxial blockade is not recommended because may be considered for repeat attempt, but may be considered for a repeat attempt or for women who are unable to tolerate ECV with analgesia. So analgesia is only indicated when the patient cannot tolerate pain, or other thing is that when there is a repeat, you will repeat that time and the patient is having pain, so in that case you will consider. There is inadequate information comparing different beta mimetic drugs on the success of ECV, so no evidence to support the use of nifedipine as a tocolytic. There are insufficient data to support the use of nifedipine or atoziban compared with beta mimetics. So IV glycerol trinitrate was inferior to subcutaneous terbutaline for tocolytic. So subcutaneous terbutaline tocolytic is best as a tocolytic agent. Beta mimetic drugs may be administered routinely, reserved for where the uterus is tense or where a previous attempt without tocolytics have been unsuccessful. A significant reduction in incidence of cesarean has been demonstrated with administration of beta mimetic drug where a previous attempt without a tocolytics have been unsuccessful. So beta mimetics what consists of 250 microgram of salbutamol in 25 ml of normal saline by slow IV injection, or 250 microgram of terbutaline subcutaneously. Beta mimetics should not be used in women with significant cardiac disease, hypertension, and will not be effective those taking beta blockers. So you have to take a detailed history from the patient, that the patient, if you are attempt ECV, so in that case make sure that the patient is not having no cardiac disease, hypertension, you will not go beta mimetics. Maternal palpitation, tachycardia, flushing, tremor, and occasional nausea may be experienced. And what about the regional anesthesia on cesarean rate is less clear. Positive study of neuroaxial block report wide variation in technique and sensory. Anesthetic doses might be more effective than analgesia. There is no evidence that complication rate of ECV are higher when regional anesthesia can be used. So the patient can tolerate pain, you will avoid analgesia, and but if she's having pain, so in that case you will advise analgesia. How ECV should be performed? ECV should be performed at the term from 37 weeks of gestation. In nulliparous, ECV may be offered from 30 weeks. So this is also SPA, that in nulliparous you will offer ECV from 36 weeks, and usually in multi you will advise at term 37 weeks. So in nulliparous, women who have a low chance of spontaneous virgin, ECV from 36 weeks of gestation seem pragmatic. Spontaneous version in multi is common, so that's why in multi spontaneous reversion is common. So we will advise at term, but in primary gravida it is less likely, so that's why we advise primary gravida the ECV at 36 weeks. Intrapartum ECV may be considered if an informed consent is possible, providing the membrane are intact and there are no contraindication exist. So whenever the patient is in labor or in early labor, like less than 4 centimeter membranes intact, sometimes the MCQ came like this, that the patient is 2 centimeter membrane intact, there is no leaking, bleeding, then you can consider ECV to show that otherwise there are no contraindication like rupture membrane, bleeding, or leak. So in that case you will consider ECV. So this is also came as an SPA. With an unstable lie, ECV is reasonable in a course of stabilizing induction. There are limited data on this procedure, but potential cord prolapse, transverse line labor, fetal heart rate abnormalities, ECV should only perform if there is valid indication for induction. What are the contraindication? There are no general consequences on the eligibility or contraindication to ECV. Women should be informed that ECV after one cesarean delivery appear to have no greater risk than with an unscarred uterus. So in previous one you can consider ECV. It is a relative contraindication. So, what are the absolute? There is limited evidence concerning contraindication to for ECV. Only placental abruption, severe preeclampsia, and abnormal fetal Doppler or CTG are supported by any evidence. So, these are the contraindication of ECV. ECV is contraindicated where an absolute reason for cesarean already exists, for example, placenta previa or major. It is generally considered to be contraindicated in multiple pregnancy except after delivery of first twin when there is rhesus isomenization, current or recent less than 1 week vaginal bleeding, abnormal electronic fetal monitoring, rupture of membrane, or when mother decline or unable to give informed consent. ECV should be performed with additional caution when there is oligo or hypertension. So these are the absolute contraindication. You have to memorize. MCQ came from this portion that specifically contraindication. So you must have a clear concept about the contraindication. There are few contraindication of ECV. And the other thing is obviously the contracted pelvis, those having a contracted pelvis. What are the risks of ECV? Women should be counseled that with appropriate precaution, ECV have a very low complication rate. So what are that complication? We will check it out. Case report of placental abruption, large feto-maternal hemorrhage exists. Complication associated with ECV are rare. Reported that significant difference in Apgar score of less than 7 at 1 and 5 for low umbilical vein, pH level, neonatal admission or perinatal death according to whether ECV has to be performed. So the reported risk of emergency cesarean section within 24 hours is 0.5% with indication over 90% being vaginal bleeding or abdominal CTG following the procedure. The most usually the sometime after ECV, you will do CTG because it will lead to fetal bradycardia, may need of emergency cesarean section. So this is one of the complication of ECV. So the other thing is that Clehot testing shortly after ECV attempt in negative Clehot report to ECV feto-maternal were detected in 2.5, a third of more than 1 ml. In women, the estimated fetal hemorrhage was more than. So whenever the patient is RH negative, you will give her NTD injection prophylactically after the procedure, because there are some that there is chance of some feto-maternal hemorrhage that is less, but for prevention of that, that the antibodies can be formed, and so in that case on the safe side we will give NTD injection. What are the appropriate to ensure fetal safety? ECV should be only performed where facilities for monitor and surgical delivery are available. The standard pre-op operation for cesarean section are not recommended for undergoing ECV. Following ECV, electronic fetal monitoring is recommended because whenever you're doing ECV, so in that case, you will give her continuous electronic fetal monitoring. Women undergo EC who are D negative should undergo testing for feto-maternal hemorrhage and should offer NTD. So that is important point. There is limited evidence to guide no more than 4 attempts are advised. So at no more than 4 attempts are advised. This is important point. For a suggested maximum of 10 minutes overall. Electronic fetal monitoring to attempt is advised. So as one of the prerequisites is that you will do CTG. Before and after the procedure you will do CTG. ECV should be only performed where facilities for ultrasound, electronic fetal monitoring and surgical delivery are available. However, fasting administration of anesthetic pre-medication, insertion of IV access are not recommended as cesarean section is unlikely. Ultrasound should be used during and after ECV to confirm the fetal heart rate. A transient less than 3-minute fetal bradycardia after ECV is common, but should instigate continuous monitoring in a left lateral position. If persistent non-improving after 6 months, should prompt preparation for category 1 cesarean section. This is the important point and one of your SPA. For at least 3 minutes, it is normal, but it is not improving after 6 months. You will do category 1 cesarean section. Urgent delivery should all be advised following the procedure if there is vaginal bleeding, unexplained abdominal pain, or there is abnormal CTG. These are the 3 points that you will do urgent cesarean section. NTD immunoglobulin recommended for women undergoing ECV who are D negative unless the baby is known to have D negative also. A minimum of 5,000 international within 72 hours. Routine screening to fetal-maternal hemorrhage is recommended by BCS in hematology and to access where D negative might benefit from additional NTD. A strong positive more than Clay should prompt indicate fetal review. So, recommended that is you will give a dose of 500 international unit and then you will do fetal the fetal from fetal-maternal hemorrhage you will do Clay test, and if it is more than 30 ml then may need of additional dose required. So for 1 ml, if there is for 1 ml you will give 125 international you will give for 1 ml of fetal-maternal hemorrhage. When should perform ECV? It should be performed by a trained practitioner by a trained working under the direct supervision. How acceptable ECV to women? Most women tolerate ECV. They should be informed that ECV can be painful procedure, but if you will tell that if she is having pain, then we will advise painkiller in the form of regional anesthesia. The how uptake of ECV can be increased. The uptake of ECV is best increased by timely identification of the baby presenting by the breech and provision of evidence-based information. So whenever the patient came at the breech, so there must be have a you will initially advise her ECV. It is a better option to avoid the to prevent the patient from cesarean section because it is a that type of procedure that may need later on further cesarean section. So until and unless if there is no contraindication, better to advise ECV. The greatest impediment to use of ECV is non-identification of breech presentation. The proportion of undetected breech presentation at term reported as high to 20 to 35 of all breech presentation, and these have worse outcome. The possibility of breech presentation should always be considered at clinical examination to abdominal palpation by sensitivity of 70%. In the absence of routine third trimester ultrasound, particular care should be taken with the high risk group where a previous baby has been breached. Recurrence after one breech presentation is so the recurrence after one breech is 9.9%. This is also important SBA that if the one if in one pregnancy there is breech, the recurrence would be 9.9. So at every third trimester you will do at every visit you will do examination, proper examination to prevent the identification of the breech so that they can't be missed. How can ECV service be developed? There is no evidence to support any particular service model to consider a dedicated ECV clinic. What is the role of non-ECV method? Women may wish to consider use of moxibustion for ECV presentation at 32, 33 to 35 weeks of gestation under the guidance of trained practitioner. Women should be advised that there is no evidence that postural management alone promotes spontaneous reversion to cephalic. So there's a less likely may consider use of moxibustion, otherwise not recommended. So this is a short guideline of ECV. Hope you find the lecture good. If any queries, you can comment on the